All right. Hello, everybody. I am Dr. Chris Seidel. I'm one of the orthopedic spine surgeons here at the Anderson Orthopedic Clinic. And tonight I'm going to be giving you a little talk about some of the things that I see a lot in my clinic where I see patients up in Silver Spring, Maryland, and Reston, Virginia, about lumbar spine-related procedures. This is meant to be more of a bird's eye, 50,000 foot kind of view. And I'm not going to go into specifics because that would take all night, but I want you to kind of have an idea of, what are the general options and why we do what we do for each one of those options. So the title of this talk is going to be lumbar decompression versus lumbar fusion surgery. So I want you to understand kind of the basic options for surgeries around the lower back. So why is this important, right? This graph, I think, does a lot to explain low back pain. So low back pain is by far the most common thing that I see people about. And I think the most important thing to know is that not all back pain will require surgery. A lot of this will get better with some physical therapy, sometimes some medications, sometimes some activity modification, but it does not always require surgery. And to kind of highlight what I'm talking about, that back pain is unfortunately a normal part of getting older. So this graph that I included here, it shows age ranges on the bottom, and then you can just, the y-axis, consider back pain. So as we get older, what we've found looking at big population data is that back pain goes up no matter what. And it just goes up and up and up as we get older. And again, like I said, most of that does not require surgery. However, so when conservative treatments fail, that's when surgery may be considered. So there are two kind of main flavors, if you will, for lumbar surgery, and that's a decompression or a fusion. And I'm going to kind of go into when and why we do each one of those. So we'll start with lumbar decompression surgery. So a lumbar decompression surgery is really meant to relieve pressure on the spinal nerves. So to do this, that involves removing some bone, removing some ligament, and sometimes removing some disc material that are putting pressure on the spinal nerves. It does not involve fusing the bones, although sometimes that can become part of the procedure, but for different reasons. So the main goal of a decompression surgery is to relieve pain, usually felt in the legs, things like numbness and tingling, sometimes weakness, but mostly leg pain. If you have back pain alone and no symptoms in your legs, this is usually a less effective approach, but can sometimes still be considered. So some common conditions that we treat with a decompression would be lumbar spinal stenosis, which is a narrowing of the spinal canal. So the way I explain this to patients when I'm seeing them up in Silver Spring or Reston is that if this is the PVC pipe for all the nerves in the spinal canal and it's supposed to be this big, stenosis is when it's narrowed to about this big, but the same amount of stuff is still in that pipe. So you can look at my images here, and the bottom left-hand one kind of shows you what spinal stenosis looks like. So there should be plenty of room for all those nerves in the spinal canal. And when they're all crowded into the center and narrowed, that's spinal stenosis. So another thing that would require decompression is a herniated disc that's putting pressure on the nerves, such as what you see on the bottom right image here. Sometimes that disc material pushes back and compresses those nerves, and that can cause a lot of pain running down the leg. Sometimes when the facet joints, which are those kind of small joints that are behind the canal on the right and left, they can become arthritic just like any joint in our body. So if you've ever seen somebody with terrible arthritis in their knuckles and they are big and swollen and angry, well, unfortunately, facet joints do the same thing as they get more arthritic. They get bigger, they get swollen, they get angry, they create bone spurs, and sometimes We call it hypertrophy when they get bigger. Sometimes that hypertrophy becomes enough to put pressure on the nerves that are coming out of the spinal canal or within the spinal canal, and that could also necessitate a lumbar decompression. So the next flavor, so to speak, of lumbar surgery would be a fusion surgery. So what is this? It's going to be a surgery that's meant to stabilize the spine by permanently joining two or more of the vertebrae. We do this by putting bone graft in and using instrumentation like hardware that includes screws, rods, and cages made out of titanium, in effect to create a bony fusion across the vertebra. So the main goal of why we're doing this is to usually stop a painful motion between one or more vertebra while also creating more room for spinal nerves. We also do this sometimes for deformity, but that's a little bit of a different topic altogether. So just to kind of show you what this sort of looks like, an x-ray down in the bottom right-hand corner shows what a typical one-level lumbar fusion where we remove the disc, we put a titanium cage where the disc used to be, we fill that cage with bone graft, and then we use screws and rods behind it to lock things in together while the fusion happens. And fusion takes anywhere from 3 to 6 months to really happen. So some of the common conditions that usually require fusion would be a spondylolisthesis. The best way I can describe this is when one vertebra slips on another vertebra, like what you see in the bottom left-hand corner. They're no longer lined up. And unfortunately, when they slip out of alignment, that usually means something is going to be pinched, usually something within the spinal canal, but sometimes also in the foramen where the nerves are exiting. Another reason we do fusions are when there's a severe degenerative disc disease, meaning that the disc have completely collapsed and the two vertebrae are rubbing against each other. Occasionally that becomes so painful that a fusion is necessary. Also, patients who have had more than one disc herniation, we call those recurrent disc herniations. Sometimes that also necessitates a fusion because those patients will continue to herniate if they've done it more than a few times. So we remove the disc and fuse at that time. Spinal deformities, as I mentioned before, things like scoliosis or kyphosis, which is that kind of position where you see somebody very hunched over in their upper body. Sometimes, not always, but sometimes those require a fusion surgery as well. So to muddy the water even further, there are several different ways of going about lumbar fusions. And the thing about spine surgery is that there's no one way to solve each problem. So, for instance, when you break a bone, the answer is that you fix the bone. If you have a bad knee or hip, you replace the knee or hip. But in the world of spine surgery, there are a dozen different ways to treat the same pathology. And so I'm going to go through some of the more common ways we do this. So one would be just a posterior lumbar fusion. So this is when we use bone graft placed behind the spine. That acts as a scaffold for your body to then grow more bone in and fuse across. We use screws and rods to create a support structure while that happens. And we often combine this procedure with a decompression of the neural elements. In this procedure, though, the lumbar disc is not removed to aid in fusion. So there is no titanium cage that goes where the disc used to be. So when we do remove the disc and put a titanium cage, that's called an interbody fusion. And there are several different ways to go about approaching this. And there's no wrong answer. The choice in the way we go about doing this is patient specific based on their problem, their specific anatomy, and what their goals are. So there's a posterior lumbar interbody fusion, which is from the back, and just off to the side, but also from the back, is a transfemoral lumbar interbody fusion. These are very similar. It's just a slightly different angled approach. When we start talking about anterior lumbar interbody fusion, that's when we go through the belly. So those are usually done with a co-surgeon that is a vascular surgeon or a general surgeon or sometimes a colorectal surgeon. And they will aid us by moving the belly contents off to the side so that we can access the disc from the front. This allows us to place a very large titanium cage, which often is a better source of fusion. There's also lateral lumbar interbody fusions, which is where we come in from the side. All of these are usually coupled with instrumentation from the back, meaning the rods and screws. But if we do that from the front first, it's just less work we have to do from the back. There's pros and cons to all of these approaches. And like I said, it kind of depends on the specific anatomy. And I'm not going to go into detail about when and where for each one of these. It's very patient specific. And it depends on each person's anatomy and what the problem we're trying to address is. So if you have any specific questions about these, I would encourage you to come see me in one of my clinics, either in Silver Spring or Reston, so that we can talk about this. All right, so let's talk about the outcomes and the success, because that's really what we want to know, right? So for lumbar decompression surgery, this relieves leg pain 70 to 90% of the time. It's a very successful surgery. I would say 70 is actually probably low. 90% is probably more accurate. This is definitely going to improve your walking ability and your activity tolerance. Generally, the recovery for this compared to a fusion is quicker because we're not waiting for that fusion to happen, which takes time. We really just need the muscle, the tissue, and the skin to heal up over top of what we did, and that's really it. A decompression, like I mentioned, though, is less effective if we're just talking about isolated back pain alone without any symptoms in the legs felt, especially when you're up and moving around. So for fusions, these have a very high success rate, 85 to 95%. The pain relief is pretty consistent. It can range anywhere from 65 to 90, but again, that range depends on the severity of the symptoms, the severity of the pathology, and the patient's anatomy, and again, their goals, what they're expecting. A big question that I get asked a lot is, if you fuse my back, does that mean I won't be able to move or bend or do anything? Usually those patients who come in don't have a lot of motion in their low back to begin with, secondary to the pain. So I tell them, you lose about 10% of your range of motion per level that we fuse. And so I tell them that they're usually not going to notice much of a difference at all anyway, because they usually don't have a lot of motion to begin with because of their symptoms. The best outcomes for a fusion surgery are when we do it for instability or a spondylolisthesis or in a severe deformity. So let's talk about decompression versus fusion. So what are some key differences here? So decompression, this is going to remove pressure on the nerves. It's going to preserve the spinal motion, and there's a faster recovery. Now a fusion, this is the only way we can give stability back. Plus or minus, sometimes we also need to decompress the nerves at the same time. So fusions are often coupled with a decompression. This is more invasive than the decompression alone, however, and does require a longer recovery. But the long-term stability of a fusion, if done for the right reasons, is very good. So I'm going to kind of summarize everything we talked about. What's the take-home message here? So both surgeries aim to relieve pain and improve function. Decompression, that's best for when we're treating nerve compression, which is usually leg symptoms. A fusion, that's usually best for instability, deformity, or when the degeneration is so severe that the pain is intractable and intolerable. The success of each one of these depends on choosing the correct patient for each problem, and that's a long discussion that needs to be had with your surgeon. And we need to talk about what your goals are, and If we're looking at your back and there are lots of different areas of pathology, we may be deciding to narrow our scope of surgery and just go after the worst levels. So the success depends upon a lot of patient-specific factors, and that's something that we have to spend a good amount of time talking to each other about. So I would encourage you, if you have questions about things that are going on in your body related to your low back, come see me in one of my clinics and we can talk about what might be best for you. You always want to discuss, the risk, the benefits, and the alternatives with your surgeon, because there are lots, like I mentioned before. In spine surgery, there are many different ways to approach each problem. It just depends on, what you have pathology-wise and what your goals of the surgery are. All right, at this time, I think I'll open things up to questions. All right. So the first question about lumbar decompression: is there any harm in waiting? That's a very good question, and it's hard to be specific in the answer. So it depends on the severity of the symptoms that you're dealing with. There are certain red flags to watch out for. If your symptoms seem to be progressive, meaning your legs are getting weaker, or if your legs are getting more numb or tingly, if you start to notice any problems with bowel or bladder function, or if you feel like you're at risk of falling because of your symptoms, those are more concerning symptoms. I want to call them almost red flags that tell us probably sooner rather than later we're going to need to take the pressure off those nerves. But barring some of those symptoms, we can wait and see. Sometimes people do improve for a while with physical therapy and medication alone. All right, next question. Is there anything that I can do before the surgery so it'll be more successful? Absolutely. One of the main things that I think people can do to make them more successful at recovering from a surgery is prehab, so to speak. So the physical therapy, even if it doesn't solve the problem, if you increase the strength of your core muscles, increase the strength of your back muscles, and increase the flexibility around your low back and your hips, you will be in a better position to recover from a spinal surgery, whether it's a lumbar decompression or a fusion. Will I be in a lot of pain after surgery? What will be done to relieve the pain? So yes, there is no pain-free surgery. You will have discomfort after surgery, but we do give medication to bring it down from here to here. But nothing will make you pain-free other than time and healing. But we do give pain medicine to help relieve the pain after surgery. The kind of funny thing about recovering from spine surgery that most people don't think of is that the more you move after surgery, the better the pain gets, actually. So what we don't want is for people to try to sit at home and not move because they think moving is going to be painful. Moving actually helps recover from the pain. All right, let's talk about the questions for spinal fusion. Why is this surgery recommended for me, and what are the benefits? So as I alluded to earlier, fusions are recommended when there is severe degeneration, if there is an instability in your spine, or if there is deformity. Those are the main reasons that I would recommend a fusion surgery. Occasionally, when I want to just do a decompression, but in doing the decompression, I feel like I'm going to be removing too much bone in order to get the nerves decompressed adequately, that would create instability. And in those situations, I would also recommend a fusion. What can I expect during the recovery period, and how long will it take? The way I think about the recovery period for most of the surgeries, specifically though, I'll talk about the fusion, is in terms of threes. The first 3 days after surgery, that's when the pain is going to be most severe. You're going to be wondering, why did I let Dr. Seidel do this? That's when we give you the pain medicine to bring it down from there to here. After that first 3 days, you kind of get a little bit used to it. And then it's 3 weeks or so until the skin, the muscle, and the tissue heals up over top of what I did. Once that happened, pain will drop off again, because a lot of that initial pain is the incision that's kind of rubbing while it's trying to heal. And then 3 months, like I mentioned, is how long it takes for bone fusion to really start to happen. Once that starts to happen, pain will drop off again. It takes a full year for maximum medical improvement, though. This does not mean you're going to be debilitated for a year. Most people are walking the day after surgery. Most people are doing many of their normal daily activities within 4 to 6 weeks. And most people are back to pretty much normal life by about 3 to 4 months. But it does take more time than that for the surgery to fully mature in your body. All right, some more questions. How long will the surgery affect my ability to do my job and daily activities? Well, that would be highly dependent on what your job is and what your daily activities are. So that would be a conversation that we would have to have in person. So if that is something you're interested in finding more information about, I would encourage you to come see me in one of my clinics, either up at Silver Spring or in Reston. What are the signs or red flags that would require me to see a doctor immediately after surgery? Yeah, that's a great question. So things that we get really worried about after surgery are if the symptoms in your legs, meaning numbness, tingling, or weakness, are getting significantly worse, or if you start to have a fever or chills. Those are things that would be red flags that we would want to see you back immediately after surgery. Do I need to wear a brace, and for how long? So not everybody needs a brace. I typically only use braces for bigger fusion surgeries, but occasionally, depending on a case-by-case situation, I will use them for other patients as well. Not everybody needs a brace. What a brace does is adds a little bit extra support while your body is doing some healing, and sometimes that can reduce pain. The brace is not meant to hold you together from the surgery. It is just meant to relieve a little bit of pain, and not everybody needs it. If you do need a brace, we usually use it for around 4 to 6 weeks. And then we really want people to get away from it, because we want you to use your back muscles, your core muscles, to stabilize. And we don't want the brace to do that for you. Any other questions? All right, everybody. Well, thank you very much. I appreciate you taking the time tonight to come listen to me talk about your lumbar health. And again, if you have any further questions or feel like you would like to talk to me more about this, I encourage you to make an appointment to come see me in one of my 2 clinics, either up in Silver Spring, Maryland, or in Reston, Virginia. Okay? Thank you, everybody, and have a good night.